All right, we're here. Let's go. We got an hour of power, and we want to get after it. So, without any further ado, I'd love to just remind you who Gail and Pat are. They're ambassadors with the Davis Phinney Foundation. They're extraordinary leaders in the caregiving space. Gail comes to us from Boulder, Colorado. She lost her beloved Jean more than 5 years ago now, and
hmm
has just continued to serve the community in an incredible capacity, as many of us know. So, Gail, love you.
Thank
Thank
you.
you for being
Thank,
here.
thank
Just
you,
a,
Connie.
just a beautiful soul. And Pat is deep in the struggles of helping his wife Sid with her, as many of you know, difficult journey, a really challenging journey. He's really informed himself and is really a leader in the space in Las Vegas, as well as being a dedicated school teacher. So, Pat, we love you. Thank you
Thank
so
you.
much for being here.
Thank you. I'm not
Um,
in the truck this month, so
you're not in a
that's
truck. I know quite often we have him escaping school and sitting
yeah,
in his truck. So you are so dedicated. I appreciate you so much.
thank
Um,
you.
and we've got a really special guest today. We've got Sarah Gilloth, who is a psychologist. And I'm going to let her introduce herself. But, it's so hard for us, all of us, to find adequate, informed mental health care. And Sarah has a lot of experience with people just like us. And so she's going to give us as much good advice as she can today. She is not going to be prescriptive, but she is going to give us a lot of, I think, support, as well as you'll be hearing from all of us too, Gail and Pat. So, Sarah, just tell us a little bit about your background.
Sure. Hi, everybody. Thank you so much for having me. I'm from Littleton, Colorado. I'm a geropsychologist, which means I just work with older adults and their families. I was at the staff psychologist at the VA hospital for about 11 years. And there I worked in what's called the CLC, which was the nursing home. I did home-based primary care, so went into people's homes, did outpatient geriatrics and caregiver support program, all in my 10, 11, 12 years there. I also did my internship there. And then I transitioned to private practice about 11 years ago. So I run an outpatient mental health practice for older adults and their families and see people dealing with anxiety, depression. I see some people who aren't caregivers, and I see some people who don't have neurodegenerative issues. But I also, a large part of my practice is working with caregivers. I have a background of neuropsychological assessment. I don't do that anymore, but I can certainly interpret neuropsychological assessment reports, which can be really helpful for caregivers to help them understand what is happening, what relative strengths and weaknesses are, so that we can best manage their caregiver concerns. So yeah, that's me.
Great. Thank you. Thanks for taking the hour to be with us. We really appreciate it.
Absolutely.
We should appreciate you. So we had three questions that came in ahead of the meetup today, and I know at least one of you are on. And I don't know that we're going to be able to help you that much, Pam, but you did ask us about the use of anti-anxiety and antidepressant meds with people with Parkinson's and Parkinson's related dementia. So, Sarah, we talked a little bit about this, what you can and cannot say, and maybe kind of take a different tact on this one. But
Sure, sure. So I'll say, with medication in general, it's so unique how people are going to respond, whether they have Parkinson's or not. And so, there's trial and error that goes with that. I mean, I think it's not uncommon for sure for somebody with Parkinson's to try an antidepressant or an anti-anxiety medication. And even within the classes, so and what I know we had talked about, there's going to be so many questions, so I could get in the weeds with all of this, but there's lots of different types of antidepressants. There's lots of different types of anti-anxiety medication. If you think about like benzodiazepines, for example, are anti-anxiety medications, but they can increase fall risk. And with Parkinson's, we're already concerned about fall risk. So I think those are real questions to ask, your providers and a specialist, but there's certainly often a role for using those medications early or later in the process. And certainly for the caregiver as well. So not just the person who has Parkinson's, but the caregiver might benefit from those medications. I'm as a psychologist, there are some psychologists that prescribe meds, but I don't. So I really work with non-pharmacological interventions, so more around cognitive behavioral interventions that we can talk more about as we go, to try to either complement the use of those medications, or if people don't want to use those medications, try to really work at it from a behavioral standpoint.
Yes, and like exercise, right? I mean,
Sure.
there are many things that you can do. But also, we just did the first comment we got in there was, I am a better care partner since I started an antidepressant, and that's a sign that you're actually looking, for help, which is great, right? Because it's been prescribed to you, and it has helped you. So there's certainly that aspect of it, and I really appreciate you mentioning that. Um, and I think that's important, right? But yeah, I don't think we can speak too specifically to that. And I think that's a question for your own neurologist, or if you've, talked to a neuropsych, and of course the family practice doctor. So, and in a perfect world, you'd see a psychiatrist to be properly evaluated, probably for what kind of medications might help, and a neuropsychologist who might understand these complicating factors like balance and the other issues that we have. But that's great. Let's just leave it there unless Gail and Pat, you want to weigh in, because we can go to another big question. Here we go.
I just find that it was an eye opener that Parkinson's has anxiety. A symptom of Parkinson's is anxiety, and it's not just the typical anxiety that you and I have.
Yeah.
It's a chaser. You can chase that till the cows come home, and you still have anxiety. And everything. So exercise and the other modalities that are available
And I think
versus
you've done a great
medication.
job with recognizing that with your person with Parkinson's, right? And talking, and you're able to talk about it. So that's another big part of
Yeah.
it, right? Is recognizing when Sid's feeling super
Yeah,
anxious.
I have to ask all the time, is this Parkinson's or is this something else? And we have that communication, and communication is very important.
Yeah.
Um, but I promise not
Yeah.
to get into it too much.
Okay. All right. No,
I
but that's helpful. Yes, Gail.
I have a question. I know that before we would get on an airplane, my husband would absolutely become just tremble and shake and everything. And I would say, "What's wrong?" He said, "I don't know." I said, "Are you anxious?" He said, "No." Is that anxiety? I mean, if his whole body reacted with in a way that he didn't feel was that he was anxious. Are
I
you
mean,
familiar with that?
I think travel in general can be just anxiety
Right,
provoking, right?
right.
I mean, just all of the strain that goes along with travel, all the
Hmm.
stimulation that comes with travel, just the overload
Right, right.
that comes even us, like gearing up for travel.
Yes.
I think some people, we talk about anxiety or depression. There are people who can recognize, like, oh, this feels like anxiety, this feels like depression. Some people who don't really know how to label that or name it.
Okay.
So I think it can absolutely still be that, even if the person themselves is like, I don't think that this is what this is. And even with, if I'll comment a little bit about depression and anxiety specifically, we have different measures that we'll use to, like, symptom checklists to ask people. So I'll have clients come in and say, I don't think I'm depressed. And I say, okay, let's just talk through what's been going on for you. And then I'll say, is it okay if I run you through just a checklist? And then we ask about specific questions, and they're saying yes, 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 yes. And then it's kind of like, oh, I guess that is what this is.
Yeah.
So sometimes just helping people name what that is and not get too in the weeds with diagnostic labels, because that isn't always helpful either. But to say, when you're feeling this way, these are a few things that we can do. And travel, I talk to people about travel, especially people who do have some cognitive impairment and they're about to travel, really trying to gear up and anticipate that, because that's where we see a
Yeah.
lot of the behavioral symptoms of dementia skyrocket with travel. It's
Yeah.
just really it keys up a lot of different things, including the caregiver, who
Yeah.
then the care
Well,
Oh, that's
recipient is
that's
responding to. Yeah.
yeah,
Yeah.
like the
yeah.
TSA line.
Uh,
But yeah, I think I would say that yeah, I mean, I know for sure with Davis that just walking into the airport is so anxiety inducing. It's stressful, and that makes everybody, if you've been with someone long enough, you also like feel their emotion more acutely too. It's hard to block it out. So I think that's important. Well, let's jump to the next because I think it's an important one, and I don't know how easily we can answer this. It was a three-part question. So this is from Jane, who asked, how do you know when cognition is declining? That was the first part. She wanted to know a little bit more about how you know if it's Lewy body dementia, which I don't think we can actually really help too much with, although I think we do have some excellent resources online. And Gail, of course, has personal experience with that, but how you tease that out. Sarah, I'll let you address that, but I don't think that that's part of your purview, is probably. And then she's also wondering how to prepare for an appointment. We talk about this too, and I think this is another link we can put in there, but how to best prepare for an appointment. And I don't know if it's a neuropsych appointment, but let's assume it is, and talk a little bit about how to best prepare for that kind of evaluation, perhaps. But and the question of cognition declining, how would you start with that? How can you tell when it's declining?
Sure. So, you know, I have lots of thoughts about all of that.
Yeah.
So the cognition declining, we're always comparing it to somebody's baseline, right? So everybody starts at a different baseline with their cognition. So even, I had a history, like I said, of doing quite a few of neuropsych evals. And sometimes, even if somebody is scoring in the average range on a neuropsych eval, if they were really high functioning, if we had evaluated them in their pre any symptom onset, and they maybe were in the superior range on all these different measures of cognition, and now they've fallen into even the high average range or average or low average, that a neuropsychologist probably isn't going to call somebody that they have dementia because they're not scoring in the so-called impaired range. But that's a fall from their baseline, and that's relevant and that's important, and that's usually what care partners are going to start noticing. Like, yeah, he can still do all of these things, but he's not nearly as sharp. He seems to get really confused with Parkinson's. The most of the notable initial cognitive impairment is in this whole arena of executive functioning, and we could talk about that for 45 minutes, but I know we don't want to necessarily do that. But so when we start to see people have problems with abstract reasoning, planning, organization, shifting course, something as simple as we were going to make steaks for dinner and they go to the grocery store and they're out of steak and they can't shift to let's switch to chicken, but they feel almost kind of immobilized by the inability, like lack of cognitive flexibility. So when you start to see those kinds of things, I think you as a family member will start to notice some differences. I always ask people when they're, when somebody's saying, I think something's going on with my husband's cognition or my mom's cognition, I'll say, is anybody else mentioned anything, like a friend, a sibling, an adult child?
Yeah.
And that when you start hearing from multiple people that they're noticing some differences, that's usually indicating that we're falling below baseline. In terms of Lewy body dementia, I'll just talk about that really quickly. That's really, probably more of a neuropsychological or neurologist question. Generally with Lewy body diagnostically, somebody will start to have cognitive problems a year or so before they develop the motor symptoms of Parkinson's. Whereas with Parkinson's dementia, people develop more notable cognitive impairment after the motor symptoms. So that's can be a way to differentiate that. That's a really simplistic, I'm simplifying that greatly.
Yeah.
But that's one way with Lewy body dementia. Also with Lewy body dementia, we're seeing more visual hallucinations and then some more sleep disorder, REM sleep disorder stuff. So but yeah, I would encourage a conversation with a neurologist. Yeah.
And one thing I'd add there too is, and Gail, you may have some thoughts on that one you guys are starting to notice? Because I know for sure Jean knew, right, that it was probably most likely Lewy body, but
Yeah.
your husband was a physician, so that made a
Mhm.
difference. But I did want to add too that there's a few things that factor in, that every care partner notices when our person doesn't sleep as well, or if they've had a trying day, if they've had any setbacks, then the cognition seems worse, for many of us who observed that. So sometimes cognition is a real moving target, right? But I think to your point of asking other people, friends and other family members, this is where it's so, it's incumbent on us to keep our family members and our friends informed so that when they
Yeah.
do see your person, they can, or when somebody can see my person and they can know what I've been dealing with, and then they can say, my children, for example, Mom, you're overreacting. Dad's fine, which of course he's not. But but they also want to see your person as better than they are sometime too, so it doesn't always help. But I think keeping them informed is really good. And it's also just asking, like, what are you noticing? And give them time to answer that. I think that's important.
Yeah.
Um, yeah, yeah.
Years before my husband was diagnosed with Lewy body, and we know it was Lewy body because he donated his brain to the University of Miami Brain Bank. So they came back with an extensive report. Um, the sleep patterns were like being in a boxing ring. I was always trying to protect myself. He was always, and he did some research on it, and he said men's men's sleep disorder, they dream about protecting their wives or partner, and the women, their disorder, it tends to be more towards running away. So one night he got up and he started laughing. I said, okay, what was it now? And he said, well, I was trying to protect someone from putting butter on your broccoli. So he was he knows I'm always watching my weight. But it was major. I mean, I was used to sleep preparing myself to be punched. Also, his extreme low blood pressure. I mean extreme. He couldn't even make the effort to get out of a chair before he was passing out from that. And also hallucinations. Seeing my son and niece came to visit, and he asked me why they're wearing Halloween masks. So if I, besides the dementia that goes with it, so those were the three things that really were the most disturbing.
And noticeable. And for those of you listening who are like, what is Lewy body dementia? You know, and you don't have to jump in and know that much about it if cognition seems pretty good with your person and you're not having a lot of crazy symptoms and you regularly see a neurologist. But it's a sub, I don't know how do we call it? Like a sub specialty or subdivision
Subset.
of, I don't know what it is.
It's
Sort of
It's
falls
far,
within the Parkinsonisms
yeah,
spectrum, which can
yeah,
be
right,
really
Under the
right,
umbrella.
complex.
right.
yeah.
Yeah.
And
Yeah.
it tends to be a very difficult diagnosis. It definitely is. And there are people that specialize in that and that can help diagnose that. Um, so we don't want to get too far into that, but I believe that Jane also said that they are preparing for a neurologist. So I'm assuming that they're seeing possibly a new neurologist, not a neuropsych, and that also he's had REM. I want to be clear that everybody with REM's sleep behavior disorder does not have Lewy body dementia. My husband's also had it for most of the time that he's had Parkinson's, and we've had neuropsych people on here talking about the frequency of that sleep disorder is very high, and so it is very disruptive to sleep and can be very difficult for both of you. I encourage separate beds whenever possible, sometimes
Mhm.
separate rooms because sometimes the person is quite loud in there, like Jean getting up and laughing. They laugh, they scream, they have
Kick.
conversations.
Kicking is
Yeah,
very big.
there's a lot of
Kicking,
kicking.
punching.
Yes,
You ever
yeah.
want to
So
hear Sydney swear? Sometimes that happens.
Oh, funny. Yeah. Yeah. It's a pretty big part of having Parkinson's, I think.
Yeah.
But but anyway, so I think that's important that distinction and not to get too panicked,
Yeah.
please, if you've never heard of it. And I think it's a curiosity you might want to follow at some point, but it's not essential right now. But since Jane was asking that. So in terms of going to visit a new neurologist, I'm assuming who's now you're going to go in there and you want, I think again, like anytime you go to see a neurologist, it's such a important opportunity to be able to have some time one-on-one or two-on-one, because hopefully you're both in the room with the neurologist, and ask as many questions as possible. And so I think if this is top of your mind, you want to make sure you're asking those questions. And if it's uncomfortable for your person with Parkinson's, you need to have that conversation with your person, I believe, beforehand, if possible, if it would be okay for you to converse with the doctor separately if your person isn't comfortable, or how, try to work out a tactic that's going to work for both of you. And I know Gail and Pat, Pat's got his neurologist on speed dial, probably several neurologists on speed dial, because you develop these relationships and you're able to message them with your concerns, correct?
It's real important to advocate for yourself because you have your doctor, but then you have your front office, and the doctor needs to let your front office know that these people are important. These people, whoever you are, wherever you are, that when there's something going on that we're trying to figure out,
Mm,
that the front office needs to cooperate a little bit more. I mean,
yeah.
we took a document in recently that the doctor was expecting us. He needed to sign it for who knows what it was now at this point, but we needed to get it to our neurosurgeon in Phoenix. And anyway, the front office says, "Well, that won't happen until tomorrow." And we go, "No, we walked the thing into you because you never took care of it before."
Yeah.
And so the doctor came out and signed it and gave her a little mini appointment, and everything was great. But
So, and Pat, another thing I would say, and when you're looking for a new neurologist, and a lot of people need to consider doing that, is to find out what their patient load is, if
Mhm.
possible. And if they don't tell you exactly, you might also ask them, are you doing research? And is that like half of your practice? Because unfortunately, most of the top neuro movement disorder docs are also in a university setting where they're doing research and they're teaching. Now that's great for the up, the other doctors that are coming up, but it's not so great for you because it means their patient load might be a little too high for them to manage. But what's really important to know is, do they have a really reliable and well-trained PA or a nurse practitioner?
Mhm.
Because quite often those are the people you're going to see for the longer appointments and see more frequently. And so really look at the breadth of the, not just the individual, don't just follow for a star doctor, but look at the breadth of the practice and see
Mhm.
who can you rely on there? And to Pat's point, like in Boulder, where we live, it's a little difficult because our movement disorder doctor only comes up like one day a week. The
Mhm.
PA comes up maybe 2 days a week or something like that, right? So it's a little better odds, but they can't handle too many. Now, of course, we can go to Denver and they have a much bigger practice in Denver, but it becomes a whole day experience then because you have to go to navigate a very large hospital. So in any case, these are the things that we talk about and that we want to focus on. But I'd like to go back to Sarah and see
Yeah.
what thoughts you
Yeah,
have in
no, I
terms
mean a
of
couple of
all of
idea
this.
things that come up so much are, is there a release of information on file so that you can call the doctor separately? And so this is always a tricky thing of like, when do you go so-called behind the back of your person and express a concern or ask a question? And this is always tricky. And I think ideally you've got really open communication lines And you can say, hey, I'm concerned about this. Are you okay if I reach out to your doctor about this? Or can we call together your doctor about this? But as cognitive impairment increases, if that's in the mix with somebody, that becomes harder for somebody to actively participate in. And so that whole front office staff, a lot of people are not going to talk to you unless those things are really clear with the release of information. So on the front end, trying to get that all in place and checking with their systems of how they communicate, that feels really important.
Yeah.
And then like preparing for appointments, I would just say, especially if it's a new provider, writing down as succinctly and concisely as you can, because there's never enough time, but what you've noticed about different symptoms. So if we're even talking about like concerns about Lewy body dementia, can you give examples of the hallucination that you were aware of? Can you give examples of when the person seemed really like their arousal was really off or their alertness was really impaired? Like, can you come to the appointment with that background information so that then the neurology provider can can kind of zone in on what the concern is for you with that time? Because sometimes these appointments they're often just shorter than we would like them to be. Yeah.
Yeah, good point. And if it gets, don't spend any time chit-chatting.
No chit-chatting. And then even if you're kind of rude, just like, so appreciate you seem like a great person. And can we please talk about these
We've got some urgent matters. And it sounds like in the case of Jane, she's traveling, they're traveling to see this new doctor, and it's very important. So arrive really early, try to be fresh, but don't worry if your person's not fresh. You need to be fresh. If possible, record the conversation. I always recommend that.
Ask to record
Ask
it
first. Ask first, but say, I'd really like to record the conversation because we often differ on what we hear. So yeah. And Jenna, let's go to the chat and see.
Yeah. Well, while we're still talking about sort of maximizing the time we have with doctors, there was a question that got at, what some people might call that sort of white coat syndrome. So you're seeing something happening at home with your person, you're documenting it, you're seeing, and so it inspires you to go. And then when you're there, your person seems fine. There's no sort of indication that something is going on, which I think happens with a lot of different symptoms. But you finally have those precious moments with your doctor, and you feel sort of like you can't show what your reality is at home. So Sarah, I don't know if you have any, things that, maybe those assessments, what might you do to help still collect some diagnostic and symptomatic information, even when your person is not really is presenting in a way that's not typical to what you're seeing at home and what's inspiring your concern. And then after we do that question, we're going to dig into kind of the step even before we get to the doctor and really dig into the challenge of resistance. But let's stay in the doctor's office for a moment.
So I think, again, if you've documented some things like, okay, I know he's doing okay now, or he's saying he's not depressed. So it depends what we're talking about. Are we talking about, motor symptoms? Are we talking about mood and all of the above maybe? But to be able to give really clear examples, like, like even having quotes. So, I know he said his mood is really good, but I need to tell you that last Thursday, he said that life isn't worth living and that if he had a gun, he'd use it. Like, that's important. That's important information. Now we're talking about extreme mood stuff. Or, I know he seems really alert right now, but gosh, he had a full night's sleep and we were at lunch and he was just completely drowsy and he really couldn't track what was going on. And so I think getting really clear examples of what you've noticed. I think
the specific question, and one of them was about cognition as well. So I would guess similar tactic to really document those, those challenges that you're seeing.
Yep, exactly. What they couldn't remember. They couldn't remember their grandkids' names. They couldn't remember. They asked me the same question 3 times. My daughter called and we had already decided we were going to the steakhouse for dinner and he had no idea where we were going. Like really specific things. Instead of like memory is just a little bit off or he seems a little confused, getting really specific, I think is helpful. And, any seasoned clinician is going to know that there's some fluctuations. That's almost ubiquitous with with all of this stuff. Where some people don't always present the exact same way all of the time, especially in earlier stages of various neurodegenerative disease
Yeah,
processes.
and just to interrupt on that one, I mean, most movement disorder docs will talk about this, and they do know, they understand that the patient will bump up a certain percentage. And so they're taking that into account. They know they're not fooled, you know. So, but you understand, like the person with Parkinson's is trying to present the best they can, you know, like I'm fine, you know. And it's a great trait because you know what? That's how they're managing to get through the disease, but it doesn't help you in the office because you feel like, oh man, they're not going to listen to me. You know, it's a terrible feeling. And we all experience that, you know, but I think again, it's just important to yeah, I think the documentation of it is good. And I know Gail has always been really good. She had a dedicated notebook
Mhm.
just for doctor appointments, prescriptions, everything.
Everything. And you never know when you're going to go back to this little note that you took that you didn't think had much meaning, and you go back and say, oh, that's right. Or, oh, that's right. I remember that doctor. He might
Yeah.
have stopped in one time, but everything goes. I took it every single time and
Yeah.
just jotted down whatever, whether it's important or not important. It went in that notebook.
Yeah. Yeah. Really important. Pat, anything to add on that? Otherwise, we're going to jump off, go
No,
to another
it's all good. I just want to say, I will say a couple things real quick. The person who's going to the Muhammad Ali Center, you'll find it, if you haven't been there, in that area, our neurosurgeon is across the street from it. It was a breath of fresh air. And from whatever experience we have a lot of experience in, I mean, we've been from to NIH to Northwestern to Portland, Senior Sinai, and all these places. And this place was just an open air educational moment. It's almost a spiritual experience. So that's all. That's what I have to say about the end that question.
That's really great.
Yeah.
Yeah,
Um,
that's great. And I encourage 100% for people to um, change doctors
oh yeah.
or consider other doctors. We've all done it. And especially if you've been living with this for a long time or you just don't feel heard. It takes time, it takes energy, but it can be really worth it. And I do believe most movement disorder docs have your best interest at heart, but not all of them have the bedside manner that you need and that you
They're
are going to
doctors.
thrive under. It's a disease of management, you know, and so you should be able to be managed. And
Yeah.
we've heard it many times from the best movement disorder docs that if a doc tells you there's nothing they can do, they can't help you, that's the wrong answer, and it's the only wrong answer because there are always some solutions, you know. They're not always medications. It's not always just adding a medication, and hopefully it's not, you know, it's more or less you know, hopefully you know, other modalities too. But listen, Sarah, Jenna, they just lost their office Wi-Fi, so she's had to jump off. But I was wondering if, before we go back to more questions, if because there are many, and I also have one other one that had come in before. But could you talk about how people find you and what recommendations you have for helping people to find care in their regions?
It's hard. I feel these questions all the time. So most of the referrals that I get come from physicians or come from so either primary care physicians or from neurologists. And the neurologist might refer the person with Parkinson's or Alzheimer's or whatever might be going on to me directly, or they'll refer the care partner to me directly. Hi, you're back.
She's back.
Um, so that's how people generally get to me. The
Okay.
other there's a resource called Psychology Today. Sometimes people will look for therapists that way. So if people put in aging or geriatrics, sometimes they'll see me that way. They'll come find me that way. I'm a Medicare provider. There are not many psychologists who accept Medicare, and I don't really. I don't actually understand that a lot. I think people are afraid of getting audited or something. I don't know, but it's and most older people that are 65 and above who have Medicare want to use it. So, to fund the services. So that is a real barrier to finding care when you can't find a mental health provider who accepts Medicare. So as a result, I'm full. My practice is full, and most people who accept Medicare, their practice is full. So it's a tricky way to find. But I'd say, generally speaking, to talk to your neurologist and to talk to your primary care and ask them, is there a provider that you guys have worked with in the clinic that helps with caregiver support? That's where I would try to seek care initially for somebody. That's the way I'd go about doing it. I wouldn't just call your insurance company and say, who can see me? Because it is a specialty working with, and not that you need to see somebody who specializes in Parkinson's. I don't specialize in Parkinson's. I specialize in working with older adults and caregivers. But, if those are your issues, you don't want to go to a therapist who sees kids, right? Like it really is a unique specialty. At least finding somebody who's worked in a medical setting, who has some sense of what caregivers go through, that's going to be really helpful versus just a therapist who's well-intentioned and wonderful, but doesn't have any of that background.
Yeah. And Jenna, you had a good follow-up question to that, I think. Do you want to go ahead and read that?
Yeah, apologies for my brief disappearing act. The internet, little faces on boxes, we're still dealing with it, aren't we? So yeah, one of the other themes of the chat was really about the challenge of resistance. So, we're talking about a lot of great tips and approaches when you get that far, but I'm seeing a lot of folks in the chat who are saying, my person doesn't even want to talk about this with me, or, they're experiencing denial. They're experiencing just tremendous resistance to even having a conversation. And, I think people are worried that that will continue. Well, they see a person. If we go into cognitive behavioral therapy, does that work with someone who is, not willing to try? So if there are any tactics or advice that we can offer people who are in that space, I think that's quite common, especially with, stigma that can live around symptoms like this and experiences like this. Do we have any tips as from this panel about how you might, support someone who's going through that?
Happy to start.
Yeah.
So that's hard. So let's just call that what that is. I think
Before Sarah answers, I just want to say that number one, they can be resistant, but are you resistant? And if you're not resistant, then the care partner should definitely try to get out there and find their own support to begin with, because that will help you. And when you're better supported, they'll be better supported. And Sarah, what would you say?
No, so that's so great. Because one thing that happens sometimes is I get these calls from a caregiver, a spouse, oftentimes, who a romantic partner, saying, "I really think my husband, wife needs to see you." And I always say, like, okay, do they think they need to see me? And they'll say, well, I don't know, but I think if we could just set up an appointment, I think that they will. And so, one, I can't make people do what they don't want to do. And two, oftentimes, a lot of times, it actually is the care partner who I'm going to be way more effective with. Because if we, exactly what Connie was saying, if they feel more supported, they are more empowered, they feel like they can, because I'll help with people, care partners' mood and, just grief and those kinds of issues. But then I'll also help if we're talking about like a more kind of advanced dementia process, different, they'll bring to sessions, this happened last week, and I'll be able to help with some dementia related behavioral interventions to say, okay, next time that happens, maybe try X, Y, and Z. If the person was in the room with me, they probably wouldn't tell me that that's what they were doing. They might not be aware that they're even doing that. And then they wouldn't want to talk to me about that they're doing that in front of their partner. And so, it a lot of times initially when I'm connecting with a family, I'm trying to figure out who am I going to be most effective with, and what makes the most sense. So sometimes it might feel like getting the person with Parkinson's in is the most effective, but it really might ultimately be that we spend more time with the caregiver, the care partner than the patient, or I'll do some joint sessions. So a lot of times when I'm meeting with caregivers, if their person with dementia is able to come to appointments, because I'm outpatient, I'm not inpatient, but if they're able to come to appointments, it is really nice to meet them. And I love to watch how, I at least can meet the person and I can see, what their sense of what's going on is. And then I can also see what the relationship is between the dyad. So whether it's the like husband and wife or parent child, what that dynamic is, because there's not a one size fits all situation. Everybody has lots of different relationship history that they bring to when they walk in my door. Great marriages, not so great marriages, great, parent-child relationships, and then not ones that are hard, that have
Yeah.
histories that are complicated. And now they're in caregiving roles and they're taking on different roles. So it just it can get really complicated. So the resistance, we have to try to figure out where the resistance is coming from. Is it that the person just doesn't think that they have a problem? Is it that they think that actually their spouse is the one that's more problematic, and so they don't want to agree to get treatment if their spouse isn't on board as well? I think trying to sort through that is complicated.
Yeah. Yeah, that's helpful. And I think that's true. It probably does really help see people in person and put the pieces together. But I do think that it's worth it to try to find help. And number one, for yourself. Support groups can go a long way, but they're limited. Gail, you work with a lot of people in your support group. I'm just curious, and Pat, I think you work with support groups, but do you find that most people have access to a therapist or are able to get the help they need?
I think most times they're looking for one, and I think the support groups are their therapists. And we do a pretty good job of understanding what they're going through, because you really have to be in the trenches to know what it's like for the fight.
Yeah.
So, yeah.
And I think that's such a good point too. And Pat, do you experience that as well? Because I think that, I mean, we always say,
Well,
like you've said it all the time about building your community, and the
yeah.
community of people that are living with Parkinson's.
My comment that I have it's swirling in my head is that there's a couple of things to remember. First of all, most of our people that we're working with are men with Parkinson's, and so we're dealing with the pride aspect of being a guy that there's nothing wrong with me. And so, but I see it on both ends, both the care partner and the at times with the person with Parkinson's, where they're not willing to pay attention to what's really going on.
Yeah.
But as far as anxiety and so forth goes, back to the fact that there's anxiety that we all can experience, and then there's the anxiety and depression that the person with Parkinson's experiences. And if they're having
Yeah.
a pride issue, they need to know, they need to be educated or encouraged to take a leap to find out what it is that we're dealing with. And that's the biggest thing that I see. Um,
And
and
don't you think too that just being in community with people who have Parkinson's helps you find your way
Oh,
and
oh yeah.
understand
The
sort
the
of the
people, the care
commonalities of
partners that I've
these?
dealt with that don't want to want to accept the diagnosis of Parkinson's for their partner. Simple things like leaving the Every Victory Counts manual out on the table. Um, you know, Eventually this one guy, he eventually started looking at it, and then having events at their house. People, they start accepting and diving more into their person's Parkinson's and how they can help better.
Yeah, and I think quite often, the thing I say, and it's so true, is that one attribute that helps people get through Parkinson's when they have it is to be stubborn.
Yeah.
And it can lead to like perseveration where they're just like, holding on to an idea or a thought. But it can also be sort of the way that they actually put one foot in front of the other and keep going with a disease that's really 24/7. This is a really difficult, fatiguing disease. And we can lose sight of that ourselves, even though we're around it all the time. And they have to make choices, and so do you as the care partner if you're going to stay with it. And that one of the choices is how are you going to live with this, and are you going to be able to find some humor in it? Are you able going to dig deep and find resilience? Where is this going to come from, and how are you going to sustain it? And so sustenance comes from building a community. And if you're lucky, you can find someone like Sarah who you can see on a regular basis that can assure you or guide you or at least just listen, right?
Mhm. I think like probably I was trying to think about what are the main, the bulk of the time when I'm spending with a caregiver, what are we talking about? And a lot of it really, it's grief. And it's also role changes, like adjusting to role changes. Like that is it's so complicated.
Yeah,
Whether it's about, is my person kind of bad enough where I need to kind of step in and take over some things, or gosh, I don't even know how to take over things. They always did this. I don't even know how to do that. I don't know that I
Yeah.
can. It feeling like you're demeaning somebody by taking over some things, and just all
yeah,
the over time when you talk about like this long process, it requires shifts and role changes, and that is
yeah,
just one of the hardest things that for caregivers.
yeah. Yeah, I
And
think I think too, like for me, I mean, Davis stopped driving a year and a half ago. And it would be very convenient for me if he was driving, but it wasn't safe, So sometimes you have to make choices like that, and you do have to make them together, in concert, one with the other. But you also have to then realize, well, this is going to get harder for me because I'm going to have to do more, and be more available, and be a chauffeur sometime when I don't really want to. And, so we have hard choices that we have to face too, as they come along, but it's just, it's part of the package really. But we wouldn't do it without humor. So humor is such a big part of it for us, and communication. I think that's so important. And it's not easy for a lot of us, to your point, Pat, when pride steps in,
Mhm.
it gets in the way,
It does. It does for
Yeah,
care
yeah,
partners and for, person
yeah,
with Parkinson's. I mean, I
yeah,
I deal with it. I've done the
yeah,
counseling and everything, and now I don't feel like I need to, but I probably do.
yeah, yeah.
It's never too early to start understanding what goes on at the desk with the checkbook and the accounts and things like that. My husband was always insisted I come to every single meeting with any attorney or accountant. But
Mm.
you might as well step in early and do it, because if that person passes away, at least you'll have some understanding, or at least you'll know who it is in the network that you have to contact to find out how to get educated. Sooner or later it's going to land in your lap. So find out now and be gentle about sharing learning to share the information. The other thing is, I think about when my back aches a little bit, how much it takes for me to get out and do some exercise. Can you imagine day in and day out not feeling well and then having to get out there and push yourself every single day? It takes a lot of stamina and a lot of discipline to do
Yeah,
that. And I think a lot of us say, well, just get out there and walk, get out there and do that. But when we don't feel well, we find every single excuse. So I can't blame them now that when I look back at it, or now that I'm having some backaches, I don't want to go out there and push myself and exercise, even though I know it would be the best thing for me. So I have to keep that in mind. But seriously, it's never too early to start learning about your attorneys, your accountants, and even what plans have been made for the future, getting your wills in order. And it should be done by people who are healthy and people who are not healthy. It's a
yeah.
must. Otherwise,
And to start with those HIPAA releases that Sarah was talking about,
yeah.
make sure you've done it first and foremost, with your doctors, and and your documents are lined up.
Yeah.
You
I
really do.
mean, you won't have time to grieve if you are inundated with all those decisions and having to start from square one.
Yeah, yeah. Well, we did have, I don't know if this, and Jen, I don't know where we're at. We're down to 6 minutes left, so we don't have a lot of time. But Janice was the other who wrote in with a question about mood swings with their person with Parkinson's. And of course, none of us have had that experience. It's just but I think, mood swings have to be somewhat differentiated from, the on off of medication as well, which is another, triggering part of mood swings, right? I know when my person was more, before he had deep brain stimulation surgery, he had a lot more up and down moments than, the more smoother outcome he got with the DBS. So it kind of depends where you are in the disease, where you are in the med cycle, how effective the meds are, how religiously your person takes the medications, and whether or not their medications need to be changed. Those are all medical questions, right? And then on the other hand is the mood question, Sarah, which I think that it is a heavy burden on the family when someone's moody, right?
Yeah, I mean, again, really individualized depending on what's going on with somebody, but I think trying to understand what people's patterns are, what they need when they're mood, whether we're talking about more depressed, more irritable, with just anxiety and depression in general, when you're thinking about cognitive behavioral therapy, like trying to understand, are there ways to help people place it where it belongs? Meaning like, okay, we know that I get more irritable when the medication is coming off, or, if I'm in the midst of a medication reevaluation period, and what do I need to do to take care of myself in that space? How do we help families support each other when we know, like sometimes we can anticipate mood changes, or we're talking about like Gail with travel, like, okay, we know tomorrow's going to be a big day. What do we need to do? We know that there's going to be some irritability and some anxiety. What do we need to put into place? Whether we're talking about basic stuff, like making sure people are wearing really comfortable clothes, making sure that, are they nourished the way that's really helpful for them? Are there certain pleasant events, guilty pleasures, watching certain shows, engaging in certain behaviors that we know kind of, I talk to people who have, like major depressive disorder, where they'll have definite episodes of depression. Talk about when that starts to come on and people will feel that coming on, like if you knew the flu was going to come on, what would you do? You would go and stock up, you'd get the stuff that helps you, and you would kind of prepare for that wave of what's happening. And so part of it is being able to know what our patterns are and to put those things into place earlier. I use these cards. I just have like note cards and coping cards. It's just a 3x5 note card. And sometimes we'll just put, depending on what the issue somebody is having, like when I have thoughts that, that this is all I'm going to do is decline and this is never going to get better. We might have a card here that are like things to remember, and just have bullet points of what we know to be true. Like this too shall pass. I know that I can call X, Y, and Z when I'm having a hard time. And this is what I say to myself to kind of center back into what I know is helpful and gets me to the next day. And that would be for the caregiver as well. So
Yeah.
it's really specific to the person. And then we have just, activity scheduling and activity monitoring, where we actually think about what are pleasant events for people. There's something called the California Older Person's Pleasant Event Schedule. And it's a list of various activities that are not crazy things like train for a marathon. It's going to be more, look at clouds, have hot tea, do something. These are just pleasant events that are readily accessible. And sometimes I'll go through that with somebody, identify what those things are that they like, put it on one of these cards, so that when we have a bad day, our care partner can help say, okay, let's try these things and see if they help us. And I would say, like, help, we're looking for 3 to 5% better. We're not looking for 100% better. You're having a bad day, but we're trying to just bump it up any bit more.
And Sarah, thanks. It's so great to have you joining us. I hope, I hope you'll come back.
Happily. Thank you so much for having me.
All right, everybody. Well, stay safe out there and please, please, please take care of yourself. Okay. Thank you.